That was spectacular. These are just superb. And now, finally, we have, after our penultimate, we have our ultimate lecture. Our final one, and the honor is reserved for none other than Professor Andrew J.M. Boulton. He is going to take us on that journey from this whole meeting. And those of you who have been so strong to last through this kind of drinking from the didactic fire hose, now you're rewarded with good Professor Boulton, who's going to talk to us about the long and winding road that leads to our ward. Don't let it be. Listen to Professor Boulton.
Thank you very much, David. As yesterday, I got my, could I have a first slide? I got my dictionary out, not the English American, but the English Armstrong-esque dictionary. And the translation from this came to this. So I'm going to give David a copy of this dictionary when I leave. Now, some of this is prediction. And here's a quote by the Danish physicist Niels Bohr, who said that prediction is very difficult, especially when it concerns the future. So I'm going to be careful as to what I predict from this meeting. But here is an example of the danger of prediction. This is the foreword to a book published in Calcutta in 1928 on diabetes by Dr. Bose. And Lieutenant Colonel J.W.D. McGaw, the Surgeon General of Madras, Tamil Nadu, wrote this introduction. And he said that in 1928, the common form of diabetes, that is type 2, is preventable and will soon join the ranks of vanishing diseases. Sadly, as we now know, he wasn't exactly correct. But I like some of his writing. Most of us dig our graves with our teeth, and every mile that you walk carries you a step away from the funeral pyre. So this is very good stuff for 1928. But his prediction was not good. We started, after my first talk, with the former Surgeon General, Dr. Carmano, who really gave a very enlightening talk, saying that healthcare in this country is not really healthcare, but sick care. He told us the costs of $2.7 trillion per annum on treating the sick in this country, and then went on to remark that 75% of US expenditure is on chronic diseases. He talked about health literacy and the disconnect between information and practice, and how we were not good at actually telling our patients what is wrong with them and what they should do about it. And he referred to obesity as the terror within. We talked about the war against diabetes, and over the course of any war, there will be many battles, local, national, regional, and global, and they're certainly going on at this very moment. And Carol Bacher showed us this slide of the prevalence of diabetes in aged 20 to 79-year-olds across the world, and how this is going to increase horrifically to over 550 million in less than 20 years from now. Now, today, ladies and gentlemen, is St. Patrick's Day. So I thought I'd litter the talk with some quotations from Irish writers. Oscar Wilde was born in Westland Row in Dublin, near Westland Row Station, which is now called Pearse Station. And he said that he can resist everything but temptation. And this is a problem. Every mile you walk takes you a mile away from the funeral pyre, but unfortunately, if you can't resist this temptation, the chance of you walking to get this are not very great. And I showed you the estimated prevalence percentage, rather, of people aged 20 or older with diagnosed and undiagnosed diabetes by age group in the United States. And how, look at this, over 65 coming up to 30%, and 13.5%, 14% in the middle-age group. And the frightening thing is how the ethnic minorities, we're seeing much more type 2 diabetes in young people under 20 years of age. So Oscar Wilde was right again. The only way to get rid of temptation is to yield to it. And sadly, that's what is happening in Western countries. Then we had the nice first talk from Graham Leese, who talked about the population-based prevalence of risk factors for foot ulcer. and how his paper compared very well in Scotland with our paper from the Northwest Diabetes Foot Care Study, looking at the population who have loss of monofilament sensation and so on. And how they had developed this community risk stratification in Scotland, and how this actually does work. Risk stratification, he showed, does predict ulceration. And of the people that develop foot ulcers, high risk categorization, they were 83 times more likely to develop a foot ulcer, but even more interesting, the low risk was very good at predicting the fact that they would remain ulcer-free. So the question he asked, does risk stratification predict ulceration? From his studies, it does. And it also predicts amputation. And sadly, mortality as well, but this has been a recurring theme in many talks throughout this meeting. And as you've seen, the incidence of major amputation in Tayside, which is the region where Graham comes from in Dundee in Scotland, decreasing. Then we whisked across the channel and into Switzerland, and Dieter Meyer gave this, The Hills Are Alive with the Sound of Music, but not, this was the Armstrongism title here, and he emphasized treating the whole patient. And this again was a recurrent theme, not just a hole in the patient. And that working together, we're all equal partners, and the cogwheels need to turn and will not turn if we don't work together. So the take-home message is good assessment, aggressive outpatient and inpatient management, and that may lead to a reduction in amputation rates. Then we had the first talk of Mike Edmonds, and he was emphasizing the diabetic foot patient is a very vulnerable patient. The natural history of the diabetic foot, he emphasized not only on Thursday but also yesterday, can be rapidly progressive and complex. And the diabetic foot patient requires care that is easily available, specialized, and coordinated. An ethos of urgency needs to be developed, and he showed how rapidly progression may occur in these various categories of foot, that he called the foot attack. And this is a very important take-home message. Never let the sun set more than once on a woman in labor, perhaps also on the diabetic foot. Now let's look at Jonathan Swift, another Irish writer. He wrote, real vision is the ability to see the invisible. And we need to see the invisible because progression can be without any symptoms or signs. There may be nothing other than good clinical observation. So the natural history is a rapid pathway to necrosis, Mike emphasized, and drivers to necrosis, particularly infection and ischemia. Then we had the nice lecture from Carol Backer talking about the guidelines. Implementation is a journey that involves real work and people with diabetes and providers. Then we moved to Japan, and Shigeo Kono gave a very nicely illustrated talk on the characteristics of the problems in the Western Pacific region. And he talked about the various meetings they'd had, looking at diabetic foot inpatients, Charcot, and lifestyle, and talked about here's the IDF motto, Unite for Diabetes, and how they've done so in the Western Pacific region with people from all over that region, including countries such as Mongolia, Vietnam, Philippines, and so on. Then of the first of the three talks from Jan Appelquist, and I note that the people who have three talks are all from Europe. I don't know if there's some message here that we don't work hard enough, perhaps, but anyway, that's just a clinical observation. The diabetic foot is a challenge for patients, healthcare providers, and he again emphasized the need to work together as a team, close cooperation between primary and secondary care being crucial. He talked about the need for multidisciplinary management and showed a number of studies that actually have suggested in observational but longitudinal follow-up that the multidisciplinary approach does work in terms of reducing ulcers and amputations. And he re-emphasized that amputation incidence can be a marker of quality of care, and he quoted the paper published there back in 2004, and more recently reviewed by Nicholas Schaper in the supplement to Diabetes Metabolism Research Reviews that summarizes all the main talks from last year's International Diabetic Foot Care meeting. And he emphasized the results of long-term outcome, of course, to remind us of the very high recurrence rate in periods of observation of 1 and 2 years, and of course, again, emphasizing the mortality. And then we had Vallecondedos from Rocio Jimenez Godinez, from the president of the Mexican Diabetic Foot Association, and she emphasized the need to work together, and the team should be whoever you have and whoever's interested. There's no point having an excellent orthopedic surgeon who's an excellent foot surgeon. If he's not interested in the diabetic foot, he shouldn't be a member of the team. And she talked about teamwork. And here we see the team at work, although one of our co-chairmen doesn't seem to be a part of the team here. He seems to be rather on the edge, looking, perhaps knowing him, he's probably sending a text message or working on his iPhone, or we must not speculate what else he might be doing. But again, the necessary equipment is observation, having a heart, and good clinical practice. The first of Jim Rika's talk was very illustrative on Machiavellian hemodynamics, the employment of cunning in general conduct, discussing endovascular versus surgical revascularization. Sadly, it seems that this still does go on, the fight between various healthcare professionals, between interventional radiologists and vascular surgeons, and that became a little apparent in the subsequent talks, and between podiatry and orthopedics, and we've seen evidence of that at Malvern and so on. So endovascular treatment and bypass surgery are two options, and they both have their place. This is the key message. A surgical candidate is where bypass surgery will give the best possible results with the lowest complication rate, when endovascular is technically and not locally possible, often in distal disease. Whereas an endo candidate, as you all know, if there's a short stenosis and so on, means are clinically meaningful endpoints, and Jim Rika's listed these here. And then we had the talk from our good friend Frank Pompaselli from Boston, and even he couldn't deny the rapid increase in endovascular techniques and the fall-off in vascular surgery. I'm not sure he was too happy about this, but he certainly admitted it. And he also talked about who would be the best person for percutaneous transluminal angioplasty or for surgery. And then the first of his talks, Rob Hinchliffe from London, had this very difficult title, which I thought he coped admirably well with. And he emphasized the need for working together as a team, but also with organization of the team, and emphasized how this was done down in London, his area, and keeping the multi-professional piece in order to promote and preserve blood flow to the foot of patients with diabetes. And he concluded it isn't just about angioplasty or distal bypass, it's about getting the system, the structure, the healthcare delivery organized. Now we moved off to our good friend here. I have another slide, as David knows, of mini-me, but I'm not going to show that today. And here's Dr. Gibbons, Dr. Evil here. And he, again, emphasized that there are places for open revascularization and for optimal endovascular. And again, short stenoses rather than total occlusions and so on. Later on the afternoon, we started with this nice talk by Rob Kirshner, who I worked with for some years when I was working in Miami. And he talked about new treatments. Are they super for us or superfluous? Again, another Armstrongism. And this is the University of Miami. This is the original hospital built in about 1930, known as the Alamo. The diabetic foot clinic's now over here. And he emphasized the limited use of total contact casts. But this may not be a cause. It may be that we should be using some of the things that we already have and that we're not using. Perhaps they're not sexy enough to cast or offload. He said that new treatments may not be superfluous because our current standards don't meet our needs, but perhaps they do meet the needs, but we're just not using them. Now, being St. Patrick's Day, one has to have, of course, a green total contact cast. And here is a green St. Patrick's Day total contact cast that we used in Miami on March the 17th in 2003. But we also described from my Miami group the use of, and David had described this with us before, the instant total contact cast, as David named it, and that is taking a removable cast walker and rendering it irremovable, such that even I, who am hopeless with my hands, could do this. You don't need a cast technician. And perhaps if we enforced offloading, it might actually work. And we showed this in a study from Miami and in Tucson, David showed that if you randomize people to this versus the removable cast walker, then these do much better. So the first word, removable, is the most important in the removable cast walker. So perhaps we should be applying perhaps more effectively what we have already, and it doesn't cost too much. Then we had a lovely talk from Mariana Tomic, again from Miami, who had previously worked with Harold Brem, and she gave a lovely talk on the need for good debridement and why this should be. And then our good friend Alberto Piaggesi, in his first talk, had to go and look up who this Mohs surgery was. And this, of course, comes from a dermatological surgery, and that is proper excision. And he, in a very nicely illustrated talk, talked about surgical debridement and demonstrated it with some live movies from his operating experience. It's the clinical effectiveness in promoting wound healing that's been recognized for many years, and the possibility of identifying markers of surgical targets for lesions could help in reducing aggressivity of the surgical action whilst making the effectiveness of debridement. So its joint clinical histopathological prospective studies would now be welcome. And then Jan, in his second talk, looked at the recent study by Magnus Lundhall and colleagues from Lund in Sweden, his colleagues there, and suggested that in very selected cases with ischemia, not possible to revascularize through endovascular techniques or by bypass surgery, these chronically infected neuroischemic ulcers, there may now be at least some evidence that hyperbaric may work, but it isn't indicated in most foot ulcers. And what we need, as he re-emphasized today, is good economic data to support the use of HBO. Then in my yesterday morning, at the first talk, I quoted Voltaire: "The art of medicine consists of amusing a patient while nature cures the disease." And I showed this very sad lady who I met 25 years ago when I moved to Manchester. The high risk of patients on dialysis. Too late for her. When I first met her, she had no legs. She was on peritoneal dialysis and, as I said, ischemic heart disease, had already had a bypass and was blind. This is the tragedy. Patients on dialysis are at very high risk. As Fran Game had shown, the start of dialysis is associated with an increased risk of foot ulcers. These are a very high-risk group that we should be targeting. Then Mark Granick gave a nice talk looking about flaps, grafts, and biologics. And he talked about the removal using hydrodissection with the Versajet and how useful this was in his practice, and emphasized that surgeons have a very important role in wound treatment, as shown here in two of the books that he had actually authored on this very topic. And then the first of two excellent talks by Javier Sanchez from Gran Canaria, beautifully illustrated talks, as we've just seen the second one. I couldn't lift anything out of the second one. It was such a big file. So I've got a slide from his first talk here. And the surgical experience of osteomyelitis, it couldn't have been better illustrated in his beautiful talk, so well illustrated with movies. What osteomyelitis? Often there is a need, especially if there's a septic arthritis, for surgical intervention. And he showed this supported by a number of his papers from the literature. Then we came on to the new IDSI guidelines. Warren Joseph talked about here, and he asked a number of questions, and they used the new BMJ grade, the level of evidence, secondly, and firstly, the strength of recommendation. Most of these were strong strength of recommendation, but level of evidence low. The questions comes back to clinical classification of infection, clinical observation, clinical signs. And I haven't got time to go through all these, but he did answer them. And in terms of antibiotic selection, we recommend that clinically uninfected wounds should not be treated with antibiotic therapy. Again, strong low as before. We recommend that prescribing antibiotics therapy for virtually all infected wounds, but caution that this is often insufficient unless combined with appropriate wound care, as we saw in the previous talk from Dr. Sanchez. And then Ben Lipsky, as always, tackled this very interesting challenge extremely ably. And are these the neighbors you would like, he asked? Probably not. And then he talked about bacteria, hoodlums or neighbors, and looked very well at the way that bacteria were so vital in our history and, of course, have contributed more than 10% of human genes and 90% in numbers of our cells. And he did an excellent overview of this area and concluded that when the skin is breached, commensal organisms can invade and become very pathogenetic. Bacteria in a wound may contribute to persistent inflammation and failure to heal, and microbial diversity is probably much greater than we thought previously in chronic wounds. And no unique organisms have been identified in any specific wound, but perhaps there are still some to be discovered. The way forward, he reviewed the new molecular approaches, especially from the group in Montpellier in France, how these are better improving our understanding of the skin microbiome, and he looked at and emphasized the importance of our resident skin flora, but some of these might become pathogenetic. And he then concluded, and then we had Mike Edmonds again talking about the need for antibiotics. He said does the presence of a wound in of itself make the case for antibiotic therapy? No, but although we all need to be good antibiotic stewards, he re-emphasized the need for early antibiotic therapy in those who are immunosuppressed with neuropathy, ischemia, especially in the ischemic or neuroischemic ulcer, because it is the combination of vascular disease and infection that leads to rapid progression and often limb loss. Then a nice talk from the new input, I think, to Tucson, if I remember correctly. When is a below-knee amputation actually okay? And this is a very important question, and I thought it was very well covered. The frail elderly patient who may not be a candidate for bypass, an aggressive endovascular therapy might maintain ambulation, but will it? And he talked about this versus primary amputation, and mortality he reviewed, and early amputation may be indicated in the bedridden with a septic emergency after failed revascularization, after intensive wound care that hasn't worked, the medically impaired, and after a frank discussion. And a very nice talk, the first talk about the importance of starting an amputee support group by John Steinberg, where he had done this in San Antonio and now in Georgetown. And you might be surprised, he said. If I had have known how well I would do with a prosthesis, I would have had this earlier. And I see patients who said to me after we struggled, why did you leave me so long? Why didn't you do an amputation earlier? And of course the answer is it's not reversible, it's an irreversible procedure, but often I think we do leave this too long because we perhaps view it as a failure. But I always remember a rehabilitation physician at Malvern saying this isn't amputation, it's reformation of an organ of locomotion. The doctor took my leg but gave me my life back. These are quotations. I look forward to this meeting. This is the amputee support group all month. And the amputee support group, look at these data, I think, from San Antonio, I think from you, when you were there. And this is amputee support actually led to a significant reduction or improvement in glycemic control. And they have a limb salvage team, but the patient, of course, mustn't be forgotten here, and there is life after amputation. And then Frank Papacelli looked at atherectomy for lower extremity arterial disease, and he reviewed the various mechanisms, the cost he did review, and it's not cheap. And really, there isn't too much randomized controlled trial data to support the use of atherectomy, and it's not justified for routine use, Frank told us. And then we had a second talk by Jim Riekers, who tried to look and prophesy, but didn't. But he did say in future studies of treatment for the diabetic foot, the clinical status, local tissue status, and the clinical outcome endpoint should always be defined. Then a very nice review by Joe Mills from Tucson, looking at different classification systems and incomplete classifications. And he looked at the Wagner, the PEDIS, the University of Texas, then the ischemia, looking at Rutherford and Fontaine, which are now quite old, of course, and foot infection. And they have proposed from Tucson the Wi-Fi. And I thought Armstrong must have had something to do with this. That's all he ever does is on Wi-Fi, I think. But limb amputation, a proposal, and Joe Mills is proposing this new classification system of Wi-Fi. It stands for wound, ischemia, and foot infection. And he went on to discuss this at length, and I think it seems a very interesting proposal. And they talk about a Wi-Fi index, and I think we'll see more of this in the future. This morning we started after the workshops with Peter Kavanagh's very nice talk on amputation reductions in the developing world. He told us that you couldn't define the developing world, especially if you went to the United Nations, but did look at the cost in terms of how much monthly income would it cost a patient in various countries to have the same amputation and treatment prior to that for this nasty lesion in someone who was on dialysis and already lost the other leg. And in India, it would nearly cost 6 years of salary to have that one episode treated, whereas, of course, in China, Chile, and the USA, it was much less. But he did end up with the good news, and that is from our good friend Dr. Abbas, showing that improvements in outcome in education in multidisciplinary repair are occurring thanks to the step-by-step program which is being rolled across the developing world. Then another talk by Ben Lipsky, well illustrated as always. He started with how do we define success? Well, Winston Churchill, as you know, defined success as going from failure to failure without loss of enthusiasm. But how do we define success? We carefully observe, record, and follow clinical findings, diagnostic of infection, systemic and local wound signs and symptoms, serologic inflammatory markers, imaging procedures, and secondary parameters would be microbiological response and wound healing. Seek signs of failure to respond as expected and act on them fast. Audit, track, and compare success rates. This was his message. And the second, again, I feel sorry for Rob. He's got the most difficult titles, I think, to address. Pyrrhic vascular victories, which he did try to address. How do we define, do we win a race that has no finished line? And he's discussed why diabetes might be different. And of course, peripheral arterial disease and perfusion or lack of perfusion are only one component. There are many other contributory factors that make the diabetic foot so difficult to work on in terms of randomized controlled trial studies and so on. And these are listed here. And he concluded that the patient with a foot ulcer, diabetes, and peripheral vascular disease not only is a high-risk patient, but there isn't too much robust evidence-based medicine to support the therapies we use. And he said that perhaps the randomized controlled trials in these complex patients may not be the be-all and end-all. Useful standards do exist, but we need to use these appropriately. Then the second talk by John Steinberg, as he admitted he had the easier task this year, how to set up a diabetic foot service, and he emphasized the physical plant, getting on well with your administrators has been emphasized by George Andros as well, and team leaders, not only physician, but nursing, administrative, and resident. And he discussed who was in their limb salvage team, and this slide I showed before, and the patient is now added, and that comprehensive foot care programs can reduce amputations by a significant amount. Then we had the nice talk from David Klonoff looking at technology, necessary features of effective monitoring devices for diabetes, technology, application, and adherence. And he concluded the next generation is coming. Monitoring can improve outcomes, but only if it's actually used. And we've all seen patients, I remember, and only the English people will understand this, but seeing a patient with John Day in Ipswich who came in and he had a British Diabetic Association home monitoring book, and it was urine tests. And the patient came in with all these, 2%, 1%, and then he looked at the bottom and it said, join the British Diabetic Association, 15 shillings. Now, our decimal currency had come in 5 years before this, so the patient had clearly been fooling all the doctors by bringing the same book in every week, and John Day was the one who recognized it. And self-blood glucose monitoring, continuous glucose monitoring, adherence monitors, and foot images are intended to adjust treatment, so use them appropriately. He did scare us a little. There could be hacking into this, so if we hacked into somebody, we could press a button and someone down the road could have a hypo because of delivery of insulin, so we need to be careful. And telemedicine devices, systems will store, analyze, and respond to monitoring data. And we're close to the holy grail, that is the closed-loop system, which probably isn't far away. And then we had our friend Alberto trying to understand what easy peasy means, but I did explain to him in the morning before his talk when he asked me, and he talked about the comprehensive service that he has developed there and concluded that diabetic foot ulceration is a local manifestation of a complex systematic worsening pathology. Diagnosis and therapy involves not only local but systemic stabilization, and he emphasized again the multidisciplinary approach that exists in Pisa in Italy. And then we had the last talk from Jan, the third of his series, The Economic Case for Amputation Prevention, emphasizing the need for proper healthcare economics to justify the means. And not only is it the cost of ulcer treatment, it's the cost of traveling, drugs, appliances, changes in living conditions, home care, treatment, adverse events, loss of production, loss of livelihood. So when evaluating different treatment and intervention strategies, please try to recognize the difference between resource utilization and economic costs. It's very important we get this right, because to justify setting up a foot care system, we may need to prove that it is cost effective. Then we had the second talk from Graham on how well they've done in Scotland, the Scottish Diabetes Foot Care Action Group, emphasizing prevention by screening and targeted podiatry and hopefully reducing the pathway along here. And Duncan Stein, who's sitting over there, is the coordinator for Scotland, and they have done extremely well. They're getting close to having all their diabetic patients on a good online system, basically. I'll end up with a quote from Oscar Wilde, another Irish quote. It is a very sad thing today that nowadays there is no useless information. Well, perhaps it's true there. We've had a lot of useful information, and I hope that you will take this home to stop this kind of tragedy happening, which happened, of course, in New York. A legless patient kills his doctor, and this is the sad story of Jim Rock, who didn't like his amputation, so he wheeled himself into the surgery and shot the surgeon dead. So perhaps if we take home the messages from here, ladies and gentlemen, we will not only save legs and lives, but also our surgical colleagues' lives. So thank you very much. Muchas gracias.